when you use as I say, the first, second drug, get about 60% or so of patients seizure-free. And clearly, if you give the first drug and the patient spits it out and says, "Oh, I'm not taking that, it's giving me terrible headaches," then you change it and you're not going to do combinations. Similarly, if you start the first drug and you bump up the dose and bump up the dose and bump up the dose till the patient's eyes cross and they don't get any improvement in seizure numbers, then you stop and you put them on something else. However, as often is the case, if the patient gets some benefit, if the numbers are reduced or down to very few, without side effects at a decent dose, you push the dose up and the side effects come, you bring the dose back down, then you add in a small amount of another drug that hopefully works well with it. You may have to take the first drug down a bit again, but then when you have that low dose combination, you get seizure freedom. And arguably in the literature, in the comparisons that have been done comparing monotherapy, second monotherapy with combination, tolerability is actually better with the combination, because in order to get the monotherapy to work, you have to bang up the dose until you hit side effects. Not a lot of difference, and of course often depends on the patient and the doctor and what you think is best, but the literature again supports, and much of it mine supports the fact that combinations may be a better option. It's also easier to do because if you reduce the first dose, the first drug, and you've already had benefit from it, then you might make things worse. And you don't know whether the second drug is going to actually be tolerated or beneficial. And so it's much of a guess. Whereas if you're already on a reasonable dose of a drug without side effects with reduced numbers of seizures, it's much simpler just to add in a drop of another drug that works with it to get the two combinations. And as I say, when you look at population and you look at the studies, and I'll show some of the literature, it's very much the population doesn't give you the answer. It's the individual patient. But what the population data does suggest is that combination is easier to use and arguably better tolerated, even though it doesn't sound sensible that should be the case. The biggest issue in treating epilepsy with drugs is that you have to know how to use the drugs. Many neurologists don't have time to do much pharmacology because there are so many neurological disorders that they have to deal with. But increasingly, they are, because you have to know what the drugs do, how to work with them, how to think about combining them or withdrawing them. And you need information, you need evidence for that. So increasingly, there's more pharmacology involved in the treatment of neurological disorders in general. And you need a background of at least some basic information on how it works, where the drugs go, how they're excreted, how the side effects caused, etc., etc.